All right. Good afternoon, everyone. Thank you so much for taking the time to come here and be with us for our grand round session today. As a reminder, I see many of you enjoying the lunch here in the auditorium. A reminder at the end of the auditorium to please take your food with you, as well as your drinks, and not to leave any, make sure we leave the space as clean as we found it. And also, please remember to sign in the front. And the people on Zoom, there's a link in the chat to claim CME credit. So please click on that link as appropriate. So today, I have the pleasure of introducing our speaker, Dr. Ramos, who I'm sure needs no introduction. He is a professor of clinical neurology here at the University of Miami. He's also the research director for our sleep program and a McKnight Institute of Brain Resource collaborator. In addition to many of his research responsibilities, he also takes the time to do mentorship, including being the chair of the Young Investigators Research Forum at the American Academy of Sleep Medicine, as also participates in our important outreach programs as a neurology, in the field of neurology, including the editorial board of Brain and Life. And in addition to his mentorship and his outreach, he also has a storied research career, which we'll be hearing about more, with a career focus on the impact of sleep on neurocognitive disorders, as well as neurovascular disease. And in particular, he's been focused on expanding the area of research right here in our community of South Florida, with a focus on the impacts of sleep on the Latino community, which has led to a 5-year, $13 million grant in the National Institute of Aging titled Sleep and Neurocognitive Aging in Alzheimer's Research. So if you could please help me welcome to the podium, Dr. Ramos.
Well, thanks so much, and thanks for the ones that are here in person. And I would like to welcome those people that are in Zoom online, as well as the residency interviewees, which I think we started today to interview residents. And just in case, this is my email, so you can feel free to email me with any questions. And this is the website for our lab if you are interested in further learning more about what we do and some of our publications and the like. These are some of my disclosures, and but I don't think nothing that is relevant to this talk. And I just wanted to start with a word about the Sleep Center, which is a multidisciplinary sleep center where we're here in this the sleep lab is here in this building on the 5th floor, and there's a multidisciplinary team from pulmonary, neurology, of course, psychiatry, people from the VA, and not listed here we have pediatrics and an ENT also, like for surgical treatment of sleep apnea. And this is some of the rooms that we do there for polysomnography and any of the 7 nights of the week. As well as where we see our patients in the clinic. So when you send a patient to us, this is where we actually take care of them. And over the next 45 minutes or so, I'm going to provide a brief review of sleep, circadian health, and dementia risk, and then go in a little bit into the research that we have done during sleep and in epidemiological studies. With the idea of how sleep could be an influence or a risk factor for cognitive decline and dementia. Maybe it could also be a biomarker, and it can also be an outcome or a treatment. So you have the whole spectrum of where sleep can you situate sleep within the disease process, in this case being cognitive decline and dementia. And we also will discuss a few next steps. So first of all, what is sleep? Sleep is a behavior that is characterized by being a rapid reversible state with reduced responsiveness, motor activity and metabolism. It's homeostatic, so the less that you get of it, the more that you need. And of course, it's episodic. There's a circadian rhythmicity to it. And it's important to state I say behavior because you can have behavioral interventions for sleep as opposed to just pure pharmacological or other type of activities. And also sleep, we can define it by, for example, sleep EEG. And you can see here the hypnogram where you cycle through different stages of sleep, starting with quiet wakefulness, the classic 8 to 12 hertz posterior background rhythms, followed by then N1 sleep, and then stage 2 with the K complex, followed by sleep spindles and the slow wave sleep or delta sleep seen here. And then rapid movement sleep, which is very close, at least in the background rhythms, to quiet wakefulness. And that's why we denote it here with a green bar. And every time that we cycle through one of these, it takes us about 60 to 90 minutes. And at the beginning of the night, we have a lot of slow wave sleep. And towards the end of the night, then we get more and more rapid movement sleep. And this is normal sleep architecture. Of importance, we also have different phases of the circadian rhythm. This is like the standard phase. Let's say someone that goes to bed between 10 p.m. or 11 p.m. to 6 and 7 in the morning. And this is mainly entrained through the circadian systems, of course. We have the retinal hypothalamic tract that starts over in the ganglion cell layer in the retina that projects all the way to the suprachiasmatic nucleus, and then to the spinal cord projects to the pineal gland, and you can have then melatonin that is released into the system and basically allow us to fall asleep and stay asleep. As we age, we have an advancement of the circadian rhythm. So we go to bed a little bit earlier and wake up a little bit earlier as well. And younger adults, teenagers to young adults, tend to have delayed sleep phase. And these people, of course, might be behaviorally reinforced with video games and the like, or TikTok or whatever they may be doing, but in reality, a lot of it is biologically driven by levels of melatonin that are secreted at different time points in these different circadian phases. Now, as I mentioned earlier, there are different changes with sleep with aging, and one of the earlier changes that we see is there's basically fragmentation of sleep. So there's less sleep efficiency that is normal across both men and women. As seen here, there's also a decrease in the amount or the percentage of slow wave sleep throughout the night. So once this is age groups here in this bar down here. Once you hit your mid-30s, you have a decrease in the amount of slow wave sleep, and this is going to be important, as I'll note later on. And that remains around stable throughout the lifetime. There's also, and you can see here a different graph where you can see, for example, here slow wave sleep. You have an increase in the amount of slow wave sleep when you are very young as a neonate, and then throughout the lifetime, you have less and less slow wave sleep into your 70s or 80s. Now, sleep duration should remain about the same once you are an adult. So there's always the question if you have less of a sleep need when you're an adult, and it seems that once you're middle age, that amount of sleep that you need should remain stable throughout your lifetime, even though you may have more awakenings, medications, and other sleep disorders that may affect your sleep continuity. And why will sleep be important? Well, there's an imperative now of trying to understand that sleep is really extremely important for brain health, the same way that we think about physical activity and nutrition as being one of the pillars of health. Recently, the Brain and Life magazine, which you talked about earlier, put an issue about how sleep is important to maintain brain health. Now that we're about to hit within the next decades, we're going to have a surge of older adults. In as well, the American Heart Association included in its Life Essential 8 sleep as one of the metrics for proper cardiovascular brain health. Life Simple 7 was initially launched by Dr. Ralph Sacco when he was the president of the American Heart Association. Now, 10 years later, it was included now sleep as one of the metrics the same as blood pressure, lipid control, weight, physical activity, and the like. So this is really quite important task that the American Heart Association plays there. And I will say that's even more important because we know that sleeping well will probably improve glucose, will probably improve some of these other metrics. So we may have even an additive effect. And last but not the least, in 2017, the Nobel Prize for Physiology and Medicine was awarded to these three individuals for the discovery of the genetic underpinnings of circadian rhythms, and that of course led to the whole array of different treatments and disorders to be recognized. Now, even though sleep is a behavior and we can measure it physiologically, it's also exists within what we call a socio-ecological model of sleep. And there are different things that we can do at the personal level, but there's of course people sleep within the family or a community, and that may have an effect on the way they sleep, being green spaces, being walkability, being pollution, and also there are things that we can do at the policy level. So, for example, this weekend we're going to do the daylight savings changes. So we're going to, I'm not sure if we're going 1 hour forward or backwards. It's always difficult to know, but there's right now there's a lot of push to try to abolish those changes. We know, and there's many studies showing that during that week after the change in hours, there's an increase in hospitalizations, car accidents, strokes, heart attacks, and the like. So this could have a huge public health effect. So why study sleep in neurodegeneration and cognitive aging? As I mentioned earlier, sleep is really intertwined with cognitive health. We know that during sleep there's reduced synaptic activity. There's also most of the flow of the lymphatic system happen during sleep, and this is a rodent model that was initially shown or described at the University of Rochester that shows the perivenular movement of CSF out of the brain. And you can see here the red tracer is a CSF movement of CSF out of the brain during wakefulness, and the green tracer is a movement of CSF out of the brain during sleep. And they were able to know that movement of CSF took away beta amyloid, tau, and other toxic proteins that have been associated with neurodegeneration. And this happens mainly during slow wave sleep too. Also, rapid eye movement sleep, where there's a lot of brain activity during rapid eye movement sleep, have been associated with increased brain development or cortical development, as well as a potential of being a proto-consciousness state, meaning that we don't know what a neonate is dreaming, of course, but the areas of the brain that are very active in the babies seems to be the same areas of the brain that allow for proper consciousness to appear, and and eventually have these shared experiences here that we call consciousness. And to some extent, this is at least hypothetically being facilitated by rapid movement sleep. We know that also that during sleep there's consolidation of memory, and of course sleep can be modified, which is what is very important. That we have an actionable item, something that we can actually treat, and some of these we're going to discuss. Now, are sleep disorders a risk factor for cognitive decline and dementia? There's data suggesting that meta-analytic data showing that there's at least a 20% increase of any dementia in people with sleep apnea. Those with chronic insomnia may have up to a 50% increase or 1.5. Those that have sleep fragmentation, up to 70% increase, and those that have either short sleep duration, those that tend to sleep less than 6 hours, and those that have long sleep duration that tend to sleep 9 to 10 hours, tend to have worse outcomes too, being those that sleep anywhere from 7 to 8 hours, the ones that have the best outcomes. So based on all this background, we have then developed a research program where we're trying to determine how how sleep disorders potentially affect the risk of cognitive decline and dementia. We know that, again, dementias are on the rise with vast economic and health implications, and they are considered the disease of the 21st century. And in my opinion, basically sleep disorders of any kind are actually the risk factor, or the quiet risk factor of the 21st century. And we know that minorities have over a twofold risk of stroke and dementia. And these sleep disturbances may increase the risk of dementia, but also increase the risk of other potential risk factors, such as strokes and cardiometabolic diseases that may have an indirect pathway into dementia risk. And you can see here a graph or a cartoon showing someone with sleep apnea where they have the obstruction of the upper airway in the back part of the throat. That happens mainly when they're, of course, supine sleep, and these neuroimages of the upper airway showing in a normal control, kind of an open airway here in the laryngopharynx, as well as behind the tongue. And someone with sleep apnea, you can see there's very, very small airway to begin with a lot of fatty infiltration in the tongue. And once you fall asleep, the tongue falls backwards and blocks the airway, basically because there's no muscular tone to support those muscles. And then you have consistent snoring and obstruction of the airway itself. A lot of the work that we have done recently is across the Hispanic Community Health Study, where we have studied sleep apnea along with other sleep disorders. And this is the largest study of Hispanic Latinos in the U.S. Across 4 sites. Miami, of course, being the main site in Miami, while you have Albert Einstein in the Bronx, the University of Illinois and Northwestern University over in Chicago, and San Diego, or University of California, San Diego, and San Diego State in San Diego. And this study started in 2008, and it's ongoing right now during the Visit 3. And you can see that there are many studies that were done at Visit 1, while some of the things have been repeated in terms of cognitive testing in Visit 2. There's an MRI study that was done starting in 2018 and got delayed because of the lockdowns. But right now we are, along with Visit 3, we're doing SANAR, which is our study, along with SOL-INCA2, which is another study for cognitive testing and cognitive decline. And at baseline, we were able to obtain, again, from 2008 to 2012, 14,000 home sleep apnea tests with this device, the RS Unicorder, that the participants took themselves, and they were able to self-apply. And a subset of individuals, we did 7 days of actigraphy, which is basically this watch-like device that is able to monitor daytime activity. And you can see each of the rows is 1 day of the week, and all of these deflections are movements throughout the day. And then you can see these blue areas where you can estimate when they went to sleep, when they wake up, and any awakenings during the day. And also some of these is different colors it's able to tell you the wavelength of the individual, whereas how much light do they have in the room at that time. And this is some of the data we can get from the home sleep apnea test, where you can see the airflow getting obstructed, and you have no airflow at all, of course. And then you have an increase in effort that leads to paradoxical breathing, and eventually leads to oxygen desaturation, as noted here, and reoxygenation, which that leads to a lot of reactive oxygen species that may cause different damages. And then also with the airway opening, you have increased sympathetic surge, and that with that sympathetic surge, there's an increase in blood pressure, and there's also an increase in heart rate. And through those 2 mechanisms is that we think that sleep apnea exerts a lot of its effect, either in cardiometabolic diseases or brain health. Now, in the initial data from the Hispanic Community Health Study, we observed that the prevalence of sleep apnea was actually quite high, up to 31% of those aged more than 60 males aged more than 60, and about 20% of females more than 60 had met the criteria for sleep apnea. And this is compared to other cohort studies. So for example, non-Hispanic whites, where about 4% of males had sleep apnea and about 2% of females. And this may probably change over time because there's more of an increase in aging and the obesity epidemic, but we can see how this particular group is kind of overburdened by the amount of sleep apnea that they may have. Some of the other analysis that we have done also is examining how, for example, acculturation stress and acculturation being the ability to get used to the new basic culture, like someone that immigrated from Latin America into the States. So how is acculturation stress and ethnic discrimination affects symptoms of sleep disorders, in this case, sleepiness. And we saw that those two metrics actually increased the risk or were associated with increased daytime sleepiness as an example. And we have other examples in this paper that I can send you if you were more interested to learn about this particular kind of sociocultural issue within Hispanic Latinos. Now, soon after, we have engaged then in trying to elucidate how sleep disorders lead to vascular disease, cognitive dysfunction, and then severe cognitive decline. And we have been able to publish a number of manuscripts on this topic. And one of the initial papers that we did was mainly in a middle-aged group of the Hispanic Community Health Study. We saw that the worse the sleep apnea was, the worse the person performing learning, memory, and executive function. Similarly, then we saw that this inverted U-shaped association between sleep duration and cognition, where those that had 7 hours of sleep more or less perform better than those that have short sleep duration and those that had longer sleep duration, as you can see here. We followed then that with a 7-year analysis, and we were able to see those people to see if they had or the sleep disorders that had cognitive decline or after 7 years, and we saw that those that were long sleepers at baseline were the ones that had decreased or cognitive decline in both in learning, memory, global cognition. With sleep apnea not being one of the factors, at least in this particular analysis, or short sleep duration, which came to surprise to us. Then in a study done by Dr. Sonia Kaur, who is from the neuropsychology division here, and also is interested in the association of sleep and cognition, we were able to see that even though among those that do not have metabolic syndrome or obesity, but they do have long sleep and sleep apnea combined, they perform worse in memory function, for example. So even taking away the effect of, for example, obesity or metabolic syndrome, which is very common in sleep apnea, when you combine sleep apnea with long sleep duration, those people perform worse in memory. One of the first things or first symptoms that may be damaged, of course, in Alzheimer's disease risk. Then in another study then done by Dr. Cristina Agudelo, we use actigraphic sleep data and observed that those that had longer sleep duration, longer sleep latency, meaning they took longer to fall asleep, had decline in verbal learning, memory, and global cognition after 7 years of follow-up. So they had, so in about 1,000 participants, if they had basically longer sleep duration, it took them to fall asleep between 20 to 30 minutes based on the actigraphic data, they perform worse and decline after 7 years of follow-up. And this sleep onset latency is basically a symptom of insomnia for many individuals. Now, what are the pathways that may describe sleep apnea or sleep disorders and increase cognitive decline and dementia risk? We discussed earlier glymphatic flow, where if you have decreasing glymphatic flow, you probably have increments in beta amyloid, tau, and alpha-synuclein. To some extent, the sleep disruption will increase neuronal activity throughout the night, and that may lead to, of course, an increase of beta amyloid and tau. Also, there's a series of sleep disorders and other factors that may cause circadian dysfunction, and at the same time may lead to inflammatory processes and other cardiovascular processes that contribute to neurodegeneration. While there's also another kind of, I won't say independent, I don't think they're mutually exclusive, but almost independent pathway that is poorly vascular, where you can have sleep apnea leading to increased sympathetic response, non-dipping of blood pressure, other things like hypertension, atrial fibrillation, and even impaired cerebral hemodynamics, all the things we have observed in different studies, and these may affect brain health kind of through an indirect pathway. So the limitation of the current knowledge really is many of the studies still use self-reported data. It's still a lot of the studies on dementia evaluate really older adults, where even though you may find kind of a prospective analysis, you may find some associations. Still, we know that these processes leads to 15 to 20 years in advance. And we cannot really know if reverse causation might still be a cause here. And many studies obtain single sleep measures, as well as they don't fully address health disparities. So that's why we have engaged in the current R1, which is sleep and neurocognitive aging and Alzheimer's research, where we are examining sleep apnea through abnormal blood pressure patterns, obtaining, like, for example, the 24-hour blood pressure monitoring. We try to see if things like non-dipping of blood pressure or nocturnal hypertension increase the risk of cardiac diseases, but also vascular brain disease, and through that causes cognitive decline and dementia. So in this 13 million grant from the NIH, we're in the third year now, and we're obtaining 3,000 participants home sleep apnea testing with this device called the NOx-T3 device, and also 24-hour blood pressure monitoring in subsequent nights to again examine how the associations between nocturnal blood pressure, non-dipping of blood pressure, and sleep apnea may lead to then cognitive decline and dementia risk, and increased dementia risk. Some of these early analyses from this study, which we recently published in Alzheimer's and Dementia, where we looked at basically cognitive atrophy and also increased white matter hyperintensity. This was led by Kevin Gonzalez, who's a neuroscience PhD student from UCSD. And we observed that those that are actually long sleepers had decreased brain volumes in the occipital and gray matter. We didn't observe differences between short sleep and normal sleepers. But when we looked at different age group, we saw that actually those that were younger, 50 years of age, that were higher, that we noted that an increase in hours of sleep led to decreased frontal and parietal gray matter volumes. And within those with OSA, any additional hours of sleep led to decreased total brain volume, decreased hippocampal volume, and increased white matter hyperintensity, letting us know of maybe some of the at-risk individuals that might lead to further decline, not only in cognition, but also in brain changes that we think may precede Alzheimer's disease and dementia in this population. So in summary of this section, sleep disorders predict neurocognitive function and decline in Hispanic Latinos. And it seems that the treatment of sleep disorders could potentially mitigate disparities in stroke and dementia risk. We are in the process of trying to obtain multidimensional sleep metrics. As we know, these things don't happen in a vacuum in terms of the different sleep measures. And with the idea that we could be able to really implement culture-specific interventions for sleep in this population. Now, can sleep be a biomarker or a treatment to prevent cognitive decline? Well, a recent article from the Wall Street Journal suggests that the data that we have right now may suggest that deep sleep may be the best defense against Alzheimer's disease. So try to start investing in these devices that may improve slow wave sleep. And quite a recent study is actually impressed now in neurology, JAMA Neurology. This is a study from the Framingham Offspring study. Mainly, the mean age was 69 years of age, and the majority were women, and the majority were non-Hispanic whites. They observed that they were able to obtain two polysomnographies at 2 different time points, separated by 4 years or so. And in the first sleep study, they were able, the majority of people obtained about 80% of slow wave sleep throughout the night. But they were able to observe that each percentage decrease in slow wave sleep led to a 20% increase in dementia risk. And you can see here the graph showing that if you had a decrease in slow wave sleep, basically your risk for dementia increased after all these years of follow-up, while it was less likely to happen if your slow wave sleep either increased or remained stable. And why will this be important? I think I mentioned earlier that slow wave sleep has this bidirectional relationship with beta and tau, where we know that slow wave sleep, again, increases beta and tau pathogenesis. But at the same time, the increments in beta and tau actually increases the fragmentation of sleep, kind of in a feed-forward mechanisms, where you can see that many times the mechanisms or the neuroanatomical areas that are shared between cognition and the sleep-wake centers are quite together. So it's very hard many times to disentangle if even many years before, if this to disentangle if the effect of decreased slow wave sleep is actually the cause of dementia, or the other way around, where you can have actually a accumulation of beta and tau then causing the fragmented sleep. But because of that, we actually are now trying to see if we can use sleep as a biomarker. And this is basically the data that is and the research that is being spearheaded by Dr. Bryce McConnell out of the University of Colorado. And we have the slow wave sleep data, the data that we have from sleep EEG, and using kind of this device that is a headband that is with dry electrodes that you can obtain multiple nights of sleep EEG, and then you get the slow wave sleep data and kind of create these, and through signal processing mechanisms done by engineers, you can do these kind of slow oscillations, and through them you can see if they have theta burst and sleep spindles, and then basically if the theta burst and the sleep spindles, they need to coincide with certain components, certain parts of the slow oscillation. Now, if there is a misalignment of the slow oscillation with the burst, theta burst, or the sleep spindle, that has been shown to be associated with cognitive dysfunction in some smaller studies, and even brain atrophy in some other studies. In this particular study, what we did, we analyzed data from the Knight Alzheimer's Disease Research Center at Washington University, and we were able to observe and link this to levels of amyloid and tau from the CSF, and we see that the loss of precision in these neural circuits, meaning the slow oscillations linked with the theta burst and the sleep spindles, was associated with increments in amyloid beta and tau. And as well, the decrease in theta burst was associated with very early mild cognitive impairment with the actual a clinical metric. And of course, this headband is a wearable device that can be used at home to potentially monitor people. This is very early, so I'm not saying that we can actually diagnose or follow people to see if they develop Alzheimer's, but this might be a promising way to actually use what is called a digital biomarker to determine if someone is at risk for Alzheimer's disease. Because of this, these findings, we are now embarking, or we recently submitted an R1 to the National Institute of Aging. We submitted with Dr. Wallace to examine or evaluate They already collected sleep EEG data of 960 individuals from the multi-center AIDS cohort study, where they have these home sleep apnea devices and 7 days actigraphy. This was spearheaded by Dr. Naresh Punjabi from the pulmonary department here. And what we plan to do is to do the similar signal processing techniques that we did with the other cohort to examine these oscillatory events, the spindles and the bursts, and try to link them with cognitive decline and dementia in people with HIV and at risk for HIV, which is this cohort. And the idea here also is not only because this has been an understudy group, but HIV also can serve as a kind of an early aging model, where it has been shown by the people with HIV, now that they're survived, basically they're able to live almost normal, full lives. They tend to get what are considered age-related diseases, be it hypertension, cardiometabolic disease, much earlier than their counterparts. So this will be a great way to actually also test an early aging process using these sleep EEG techniques. Now, some of the treatment of sleep disorders might be promising to also to not only use a digital biomarker and determine which might be at risk, but very recent data, and again in a very small sample, showed that suvorexant, which is a medication used for insomnia, this is out of Washington University, decreased by 10 to 15% tau protein in the CSF, and by 10 to 20% amyloid in a very small randomized control placebo trial. And usually they saw this at the highest level, which is 20 milligrams per night. And also a very recent retrospective study of Medicare claims data demonstrated that those people within that, within all these claims that have, of course, sleep apnea and use positive airway pressure based on the claims and were compliant to it, had lower odds of incident diagnosis of Alzheimer's disease. So it seems that to some extent, even though this is not a randomized study, the use of positive airway pressure could protect against dementia. And another thing that we're about to embark to is to actually try to enhance slow wave sleep. And there's, similar to the headband that I showed earlier, we are starting to partner with a company that actually, with the headband, they're able to provide acoustic stimulation through the mastoid. And by doing that, you increase the amount of slow wave sleep and actually also help to kind of be able to coordinate the spindles with the slow oscillations. And this is very early, so that's why I didn't show any data from this, but hopefully in the future I'll be able to show some data about that. And with this, I want to recognize, of course, the people that I collaborate with across the different sites. Susan Redline, who was and is a mentor in sleep disorders, and Dr. Murray Middleman, who is a cardiologist expert in blood pressure monitoring, as well as Dr. Gonzalez, who is a mentor in cognitive aging, and Taraf, Dr. Taraf, who is a biostatistician, and Dr. Ms. Barbara Junco, who is has been the project manager, and it's been great to really get this off the ground, as well as Dr. Charles Riccardi, who is an expert in neuroimaging, and of course, these are site coordinators. Needless to say, we have many ongoing collaborations in development. So we have a lot of collaboration with the McKnight Foundation, also with Dr. James Galvin of the Comprehensive Brain Health Center. I'm looking at REM behavior disorder and how it may be a risk factor, a determinant in dementia of Lewy body. And this study we also conducting with Dr. Hack here in the audience. That could be a talk upon itself. And then there's also collaborations with the translational sleep and circadian sciences led by Dr. Jean-Louis, Dr. Seixas, and also the investigators from Bascom Parmon, Dr. Cabrera, looking at retinal biomarkers of cognition in people with sleep disorders. Now to conclude, I wanted to say that We know that brain health, of course, leads to improvements or is important for vigilance, cognitive, and emotion, and again, bodily motions, bodily function. But needless to say, there are also many behaviors or things that we can intervene to improve brain health. And with this, I will take questions. Thank you. Yes, no. Hi, how are you? Yeah. So the question is, what will be the mechanism that links a slow wave with Alzheimer's disease? And this is, of course, still in development. Right. So we know, it seems that from the data from the Framingham study, that declines in slow wave sleep leads to Alzheimer's disease, or it seems to be the case. And there's some animal models showing too that with increments in slow wave sleep, you have increased CSF flow out of the lymphatic system, and that leads to, of course, removal of beta amyloid. The CSF out of the brain through the lymphatic system seems to remove beta amyloid and tau, at least in rodent models. So potentially through that mechanism could be of one way by which slow wave sleep increases dementia risk. Now the question if improving slow wave sleep may improve or reduce the risk of dementia, that's a different type of study, that's treatment studies. Yeah, that's a good question. I'm not sure. I think to some extent, and I think it might go to the work that you do. I think it has to do probably to some extent with a cerebral blood flow itself too. I think to have good lymphatic flow out of the brain, you have to have good cerebral blood flow. And if that gets impaired for whatever reason, that may either manifest as decrements in slow wave sleep, because maybe there's without flow, less flow. We know that can lead to, for example, decreased brain volumes by itself. And maybe what we're picking up with the slow wave is really the decrease in volume that was preceded by already years of decreased blood flow. Or it could be vascular damage, which either because of nocturnal hypertension or non-dipping of blood pressure. From that, I will be harder for me to speculate even more. Yeah. Go ahead, please, Dr. Haag. Yeah. So the first question is about how where in the spectrum do I see sleep playing a better role in terms of the management of and hopefully the prevention of dementia. And I think I agree with you. My hope is that we really find things that we can treat that is actionable and we can do it soon enough. Meaning middle age, to really change trajectories over the next period, over the next decades before someone develop cognitive decline or increase dementia. So I'm hopeful that that we are able that eventually we'll be able to develop a randomized trial looking at how treatment of sleep apnea actually prevent dementia risk, or at least change biomarkers. There's also one group looking at there's a safe trial. No, there's not a safe trial. I forgot the name of it, but there's a big randomized trial now. That Dr. Romano leads here in out of University of Michigan, that trying to see if sleep apnea prevents, for example, stroke risk and TIA. So that being an indirect pathway by which we know because increases vascular brain injury. Now the inflammatory processes, I think that's really more of a vascular measure or a vascular pathway by which the sleep disorders may increase dementia risk or increase vascular brain injury and eventually cognitive decline. I think that's where, for example, sleep apnea, we know increases certain inflammatory markers and also reactive oxygen species. And I think that's really another indirect pathway that really ties to vascular brain injury. More so in the population that we study, which is Hispanics, where we know that ApoE4, for example, the allele that is a classic, genetic allele for dementia risk is actually not as predictive of dementia as in other groups. So it seems to be more of the cardiometabolic inflammatory pathways more than anything else. Yeah. Sonia, how are you? Yeah. So the question is if there's a difference in the presentation of sleep disorders, and if these have an effect on the risk of dementia or at least on cognition. And so some of the things that we have found is actually that for specific for sleep apnea, even at a lower level of sleep apnea, women tend to be more sensitive to the symptoms, meaning developing more fragmented sleep and cognitive decline, or at least cognitive function associated to lower levels of cognition or sleep apnea. Also, something that I didn't touch upon here is that we have looked at how sleep apnea differs across men and women in Hispanics, and that has actually been looked at in other ethnic groups. And while men present with the classic symptoms of sleep apnea, being loud snorers and daytime sleepiness, women tend to present more with insomnia symptoms, and that might be the symptom of sleep apnea actually. And the snoring might not be as profound, of course. And usually their bed partner is asleep, so no one notices. All right. Any other questions? Yes, go ahead. Yeah, that's a good question. Yes, it seems that severe insomnia can precede or at least increases the risk of developing dementia. And of course, people also with Alzheimer's disease can also present with severe insomnia symptoms very early in the process. So this is one of the things that is very hard to disentangle early on. But again, it seems that insomnia itself potentially is a risk factor, and the chronic use of medications, be it benzodiazepine receptor agonists or benzodiazepines, can actually also increases the risk, at least at the population level. Clinical studies have been a little bit more difficult to do. Yeah. Please. Thank you. Correct. Right. Right. So the question is how the correlation between slow waves and rapid eye movement sleep may actually improve or cause increased dementia risk, or at least the coding of memory. And so a couple of things here. The sleep architecture that I showed earlier, we think that not only slow wave sleep is important for consolidation of memories. Of course, rapid and movement sleep, as you alluded to earlier, is also very important for the consolidation of memory. And we think that the sleep architecture, at the beginning of slow wave sleep, you have thalamic cortical, basically coding of newer data, if you want to call it like that. And then during rapid and movement sleep that happens later in the night, or at least the majority of it, you have more of a cortical connections, kind of that new data, that memory replay that you're doing during slow wave sleep is then being inputted into, I guess, the hard drive, and associating it with other information that you have, and then this happens during rapid movement sleep. So yeah, it's not only having the amount of each of the slow wave and rapid movement sleep, but it seems that also the sleep architecture itself, the cycling through it, is extremely important for memory consolidation, long-term potentiation too. Yeah.
Disturbed architecture of the sleep. There is studies on sound in sleep that can kind of relate to this.
Yeah, no, that's a great question. So the question is if there's any sounds or music that could be played during sleep, for example, to improve brain markers or brain health of any kind, let's say like that, in people that, for example, do not have a sleep disorder. And I think that is probably where we're trying to move now. We'll try to use this acoustic stimulation to, again, try to enhance or improve slow wave sleep. But the applications, I think hopefully will be beyond specifically Alzheimer's disease or cognitive issues. There's also some data suggesting that, for example, increments of slow wave sleep through this mechanism decreases parasympathetic tones and may have a role in cardiovascular diseases. And it could potentially have a role in other neurological processes if you think that they might be, processed through, like, this may increase brain plasticity, for example. Now that's hard to tell right now, but there could potentially be a role. Yes. Yeah. There's one question, and then I'll come back to you.
Do you think there's a correlation between slow waves, atherosclerosis, and also, is there any study that the effect of studies on slow wave?
Yeah. So the first question is if there is any correlation between slow wave sleep and atherosclerosis. Direct correlation, I don't fully recall coming across a study that specifically looks at slow wave sleep itself and atherosclerosis. We know that other sleep disorders do correlate with atherosclerosis through different pathways, and even the decrements of slow wave sleep has been shown to associate with the increased hypertension. But I haven't come across any, any studies specifically addressing, slow wave sleep with an atherosclerotic process. Now, sleep apnea does do it. Insomnia too has been associated with atherosclerotic processes. But again, slow wave sleep by itself, I haven't seen it yet. What was the second question? I'm sorry.
Again, it's related to statin use. Statins.
The statin use. Yeah. No, I don't know of any studies that have looked at statin use and changes in sleep architecture itself. I mean, of course, there's some statins that do cross the blood-brain barrier, but I haven't seen any specific studies that looked at the sleep architecture itself, associated with increments in with the use of specific statins. But I'm sure there should be some changes there, if at least for those that really do cross the brain blood barrier. Yeah. Noah?
Or where in the brain is the source of the slow wave? And what type of acoustic stimuli you try to stimulate?
Yeah. So the source of the slow wave is really the thalamic to cortical connections that happen basically during that cortical quiescence period. So it's really for the most part thalamic driven. Now, I was actually trying to look for how the mechanism of how acoustic stimulation will increase slow wave sleep. Because I knew someone was going to ask me, and to be honest, there's no at least I haven't come across what will be the exact mechanism of how this happens. It's a phenomenon. It's called pink noise, as opposed to white noise, for example, that you may use at home to help you fall asleep. This is called pink noise, and it seems to allow for this to happen. But exactly how or why, I think is still being we're still trying to understand that. Yeah.
So the source of the slow wave signal is coming from the lung side of the
Correct.
this might see, so it's the brain is because the cortex is very quiet.
Correct. Exactly. All right. Yes, one question.
Is there any explanation on that? So, as we're talking about the correction, what's the appearance of topic?
Yeah, that's a good question. The suvorexant is an orexin antagonist, and orexins are, of course, involved in the stabilization of sleep-wake processes and also in wake promotion. So, of course, here we use it for insomnia because it helps to induce sleep as an antagonist. Now, it also seems to there's a circadian rhythmicity to the production of beta amyloid and tau that has also been demonstrated by this group in Washington University, and they were able to also kind of block the rhythmicity with suvorexant, and I think that's why they were able to think that suvorexant or using an orexin antagonist might be useful, and by taking the data from those rodent models to be used in this small clinical study. So it seems that the excessive production, or even in this case, a reduction or excessive production that may happen to circadian processes might be blocked again with the addition of suvorexant during sleep. Yeah. There was one more, yes.
Genetic question on the pharmacodynamics, pharmacokinetics. And you take in the daytime, and then you take just before sleep. For instance, antihypertensive, anti-angina, or antidepressant, or statins. So what's your comment on the how sleep affects the pharmacodynamics and pharmacokinetics?
Yeah, that's a great question. I think that's so the question is in general how sleep may affect the pharmacodynamics and kinetics of certain different medications. One thing that we are learning about is and hopefully that we'll be able to apply to is more than sleep itself. Is really using the circadian mechanisms or what is called chronotherapy as a tool that to treat different diseases. So for example, there's epilepsies that may happen later at night. So maybe timing not only of the medication but changing the dose to a higher dose could be considered in using this paradigm of chronotherapy. The same happen with blood pressure, for example, or you can have normal blood pressure in the in the office, but then when you look at 24-hour circadian rhythms and cycles, you noted that they're going to have nocturnal hypertension that they may lead to chronotherapeutic alternatives and try to time and change the doses depending on what you see is the 24-hour rhythm of this person disease process. So there's also a movement to try to do that Not only limited again to these two examples, there's also a lot of cancer cancer research that's moving towards that too. And I think they're the ones that really spearheading this part. Yeah. Yeah. Thank you. Right. Well, thanks for having me.
Thank you. All right, thank you everyone who participated both in person and on Zoom for our grand round. Please a reminder to bring all your food and drinks with you when you leave the auditorium. They do have a cleaning crew coming in at 1:30, but we try to be respectful of the space. And please, if you have not signed in on your way in, please do so on your way out. Thank you very much, everyone. Have an amazing weekend.